Good evening. You're very welcome to this evening's webinar in the series on living and learning empathy in COVID-19. My name is Brendan Kennelly. I'm a lecturer in the Cairn School of Business and Economics at NUI Galway, and I'm very pleased to be the moderator of the event this evening. The seminar series, or the webinar series, as you know, is a collaboration between the Institute of Life Course and Society at NUI Galway, the UNESCO chair at that institute, Professor Pat Dolan, and the UNESCO chair at Penn State University, Professor Mark Brennan. And we are very grateful to Pat and Mark and their colleagues at ILAS for giving us this opportunity this evening to have a look at some of the issues raised by the pandemic from a health economics perspective. The overarching theme, as you know, of the webinars has been learning and living and learning empathy. And health economics has some interesting things, I think, to say about empathy, about the role it plays in the production and distribution of healthcare and ultimately health. And I think the contributions this evening are going to bring that out very well. I'm very pleased this evening to be joined by four of my colleagues from the health economics community in Ireland. Paddy Gillespie is going to be our first contributor. He'll talk about some of the broad themes and methods used by health economists. Dr. Brendan Walsh from the ESRI is going to have a look at the impact that COVID-19 has had on healthcare utilisation in Ireland. Dan Keller is going to talk about healthcare utilisation among migrants in Ireland and how that has been impacted by the pandemic. And Dr. Michelle Queedy is going to look at the issue of obesity and the particular topics and questions that arise about the treatment of people with COVID-19 who also have obesity. So our first speaker is Paddy Gillespie. Paddy is the Professor of Health Economics at NUI Galway and is also a member of the Health Economics and Policy Analysis Centre there. So Paddy, over to you.
So thank you, Brendan. Good evening, everyone. And thank you for giving up your time on this Thursday evening to listen to a bunch of economists. And I think that's a good place to start our talk this evening, because it is a fair question to ask that of what does economics have to offer when it comes to a global pandemic. And I suppose more specifically, this series of living with empathy. What has economics got to do with empathy? And I think they're two fair questions. And perhaps part of my role in this webinar and giving you a broad context, an explanation of what health economics is maybe to try to convince you of the role that health economics has to play and some of the contributions that it can make. And perhaps I won't convince you, perhaps I will, but I think, as Brendan said, people who have training in economics, who spend their time working in the area of health and healthcare, hopefully bring some of those concerns, societal concerns, and relating to empathy and other issues to the table. So as I say, I'm going to spend a little bit of the time, I suppose, setting up the talks of my colleagues later on. So I'm going to explain briefly my impression of what health economics is. And also, I'm going to spend a little bit of time talking about what health economists, such as my friends and colleagues on this call, spend their time doing, spend their time researching, the types of methods that they employ, and the types of questions that they explore. So to that end, what is health economics? Well, in the simplest terms, it is the application of the tools of economics to explore questions relating to health and healthcare. And the goal of this discipline of health economics, like any social science, is to help us understand, hopefully a little bit better, how the world around us works, and specifically as that relates to health and healthcare. So, in terms of these tools that I'm talking about, I can group them into two broad categories, or two pillars, if you like, that make up the discipline of health economics. The first pillar is theoretical analysis. So, what do I mean by theoretical analysis? So, these are I suppose, logical arguments that we develop to help explain phenomena. And then beyond that, exploration of if we were to change certain inputs to those phenomena, would outputs change, and would they change in a way that we would like them to change? And where potentially that type of analysis is useful is if you're a public policy maker and you have certain objectives that you want to achieve. Perhaps that theoretical analysis can help you inform the types of responses that you develop and implement. So that's pillar one, if you like, theoretical analysis. The second pillar then is empirical analysis. And that generally involves health economists working to design studies and experiments whereby they collect data, they do quantitative statistical analysis to test a range of hypotheses. Some of those hypotheses could be related to the theory we've just introduced earlier on. So you could test if a theory stands up, confirm or otherwise whether it plays out the way you expect it to do, and then you start again. You add to your theory. You go again and you try your empirical analysis again. So, a simple example might be that we can present a logical argument that increasing the cost of an unhealthy behavior will reduce the extent to which individuals engage in that unhealthy behavior. So if we think of something like smoking, if we were to increase the price of cigarettes via an excise tax, we could theorize that smoking levels would reduce. And that's our theoretical piece. But then to test that, we could design a study, we could collect data and analyze that data, possibly before a budget that increases excise taxes and after the budget, and test whether our theory stands up or not. So that's just a broad description of those two pillars and how often they work together to help us explore and explain and understand better these phenomena relating to health and healthcare that we're interested in. So those are our two pillars, theory and empirics. So if I take those and I draw them together and I try to think about the ways health economists can use these methods to contribute to particular debates in health and healthcare. And for the purpose of this evening, I think I can group it into four contributions or four offerings that health economics makes. So I'm just going to introduce these four contributions. And I think later on, when my colleagues talk about specific issues, they will delve in and out of these individual contributions, 1, 2, 3, or 4, and maybe they'll contribute to they'll talk about one or more of them. But that'll just give us a sense and a framework through which the other contributions hopefully will sit. So in terms of these four contributions, I'm going to say contribution 1 is a theoretical contribution, and I'm saying that health economists offer theoretical analysis of human behavior in the context of health and healthcare. So as we know, there's many behavioral sciences out there that try to help us understand how we as individuals behave. It's fair to say that even within economics and outside of economics, the theoretical models in economics are debated, are contentious, are not universally received. But then again, they do offer some useful context and some useful learnings that we can take down the line. So what am I interested in here? I'm interested in why we as individuals engage in certain behaviors, some of them healthy, some of them unhealthy. And beyond that, is there anything we can do to help policymakers achieve their goals with respect to healthy behavior and unhealthy behavior? So lots of theoretical analysis around that. A second component is the component that Brendan just mentioned, and that relates to, well, theoretically, how could we as individuals achieve the level of health we would like to achieve? And I know some of the language we use in economics is a bit cumbersome around this, but we often talk about it in the context of the production of health. So me as an individual, if I look at myself as maybe a piece of machinery, there's a range of inputs that I can channel through this piece of machinery, and it can produce an output, and that output is health or healthy days. Now, if we think of what the different types of inputs are, there's genetic factors that we can't modify, but there's a whole range of other modifiable factors. Your lifestyle, your diet, the environment you live in, the community you live in, and the healthcare services you access. If you think of all those inputs, they can go to help you to produce a level of health. And I suppose from my perspective, one of the things that's very interesting around the COVID crisis and its impact is that if we think traditionally of the Department of Health, very often the focus of the Department of Health is on one input of healthcare. Whereas our response to COVID, we as a community have come together, and very often, if you think of, I suppose, the successes in terms of maintaining the spread of the infection, a lot of this can be attributed to the community and other inputs and not the healthcare input overall. So it's just something that I suppose if you want to consider some of the impacts of COVID that I know my colleagues will talk to in a little while. Okay, so the second contribution that I'll talk to is again a theoretical contribution, and this theoretical analysis explores the role the government should play in the healthcare system. And this is framed in a theoretical construct called market failure. And the idea is that if a private market left to its own devices was left to take ownership of a particular good or service, in this case, healthcare, if it doesn't achieve the objectives that we as citizens of a country wanted to achieve, then the government should step in and play a role in that market. So again, this language is maybe sometimes alien when we think of health and healthcare, but in this context, what we're talking about is, well, why in some cases do countries have a predominantly public healthcare system where the government takes ownership of the majority of the delivery and funding of healthcare? Why in some cases do countries have a predominantly private healthcare system? You think of the US, you think of Switzerland and these countries. And why do other countries have a mix of public and private, much like we have here in the Irish context? And there's theories around this we can explore. So when we take this together and we think of COVID, I think there's been some really interesting developments with respect to the public system, the private system, the government taking over the private system, and posing some really interesting questions and challenges going forward for the type of healthcare system we will have in Ireland. Contribution 3, which I'll just briefly talk to, this is an empirical contribution. So collecting, analyzing, and testing statistical relationships with respect to health and healthcare. And I think this is where health economists play a really important role, and when it comes to empathy, shine a light on things like socioeconomic and social disparities when it comes to health outcomes, but also access to healthcare. So what groups in society have experienced the greatest burden when it comes to ill health, and what groups in society experience the greatest inequity when it comes to accessing healthcare services? And health economists, such as my colleague Brendan Walsh will talk next in the call, will talk about some of those issues and how COVID has impacted upon them, and really interesting work in that space. And the final contribution number 4, is a set of methods that health economists employ to explore the question of the value of healthcare interventions. So we've got a limited healthcare budget. We can't fund every healthcare service we want to fund, so we have to make choices. And those choices should be informed by evidence, and health economic evidence is very often one component of that evidence base. So how health economists quantify value is they look at the cost of it, They look at the outcomes it produces, that healthcare service, and they make a judgment as to, is the outcome produced worth the cost that it takes to produce that output. And this can be controversial. This can lead to very difficult decisions where certain services are not provided. But equally, I suppose the motivation of this methodology is that overall, if we spend our money on those healthcare services that produce the greatest level of health outcomes, well, we're spending our money more efficiently. We mightn't always want to focus on efficiency, but if you want to collect evidence of that, well, health economics has a role to play within that. And I think what's really interesting in the COVID impact is the fact that costs and efficiency have just been wiped away. And rightly, we as a society have come together and said, spend whatever money we need to spend to address this issue. But there's going to be impacts down the line in terms of the budget available to provide other services. And those are really difficult questions and interesting questions that will have to be addressed. So those are our 4 contributions: the theory and the empirics. And now I'm going to hand over to my colleague, Brendan Walsh, who's going to talk more specifically about a topic within the COVID related to COVID, but framed within that broader context of health economics. So I hope that was useful, and I hope you've got a sense of what it is we as health economists do. And now we're going to move on to some of the more focused contributions. So thank you very much.
So thanks, Paddy. So as Paddy says, I will discuss some of the impacts that COVID-19 has had on healthcare utilisation. In Ireland and elsewhere, especially at the beginning of the pandemic, there was a dramatic reduction in healthcare use. Some of these reductions were driven by resource allocation decisions or the healthcare providers themselves trying to free up care facilities. Or the reductions may also be a consequence of something which is quite a large element of the health economics literature, as Paddy has alluded to, which is human behaviour change. So I will discuss some of the more recent evidence which has emerged on healthcare use, particularly focusing on emergency departments, other types of hospital care, and also general practice care. So in work we published at the ESRI in mid-May, which was led by Aoife Brick, we showed that from the beginning of the pandemic here, there were large reductions in the number of people seeking care in emergency departments. So we'd access to data for all public hospitals within the country. And we saw that from the beginning until the end of March, there was a 45% reduction in the number of people attending EDs. So effectively, what you saw was within a 4-week period, there was a halving of emergency department use within this country. And this large reduction, it was seen across age groups, it was seen across different regions also. So it was really a universal thing which was seen in the emergency department system here. And we also know from the health economics literature, there likely is a number of reasons for this drop-off. So there might be fewer accidents from less travel, for instance. While we were social distancing, not only did it reduce the spread of COVID-19, but it may have also reduced the spread of other respiratory illnesses or gastroviruses, which may have reduced the demand for care. But I think a key factor is likely to be changes in human behaviour. And people were not attending emergency departments, especially at the beginning, out of fear of contracting COVID-19. So here's a good example of individuals trading off risks. And in many instances, the fear of COVID-19 was seen as greater than the perceived need for accessing emergency care. And at the time, a lot of clinicians and the chief medical officer himself were quite worried that because of this fear, people were not accessing the emergency care they needed in a timely fashion. And one other interesting element which could be driving the reduction too is, driven by social pressures or the advice or wanting to follow public health guidelines and to help flatten the curve by remaining at home. And this could also have had an impact on the demand or the use of healthcare services here. And these points on public behaviour impacting, ED use, it's epitomised by the fact that we actually found that the reduction in attendances began to fall in the days following the first confirmed case of COVID-19 here on February 29th. So within the week or two, even before the first restriction measures were announced by the Taoiseach in mid-March, there was quite a sharp drop-off in emergency department activity here. Now, the story seems to have changed quite a bit recently. We don't have the micro data yet, but it's something we want to look at in the near future, is the rebound during the COVID crisis. So we have evidence from the HSE that from March especially, there does seem to have been a rebound in demand or the use of emergency department care too, which does get to the point that a lot of people may have been putting off care for a certain period of time. But this pent-up demand is now being realised in greater utilisation of emergency department services. Also, as Paddy alluded to, the allocation of resources is quite an important part of the health economic literature. And within the hospital system here, we actually saw quite a stark example of this. So within the acute hospitals, from the beginning of March, a lot of scheduled care or elective care was cancelled, mainly in anticipation of a potential surge in COVID-19 cases that, based on the terrible experiences of northern Italy, it was really felt any surge would have the potential to overwhelm the hospital system here, because in Ireland we were starting at quite a low base in terms of our capacity. So when you compare us to other European or OECD countries, in terms of hospital beds per capita, or especially intensive care beds per capita, we were quite low on the list. But there has been knock-on effects to the delays or the removal of elective care. We now have a much bigger issue when it comes to waiting lists and waiting numbers and the length that people are waiting for different types of care. And we're not just seeing that within the hospital sector, we're also seeing that within the community sector too. So a lot of people who would have received physiotherapy or occupational therapy or speech and language therapy, for example, in the previous few weeks didn't. So there really is a pent-up demand at the moment across the different parts of the system. And unfortunately, this will mean that for many people, they won't receive the care they need in a timely manner. Their health and their well-being and their quality of life may suffer and may deteriorate at a greater rate than it would have before. So as we do continue to live with COVID-19 and hopefully in the near future come out of this crisis, we will need policies designed once more to increase capacity to allow individuals to flow once more through the system and start treating these individuals and patients who are on waiting lists. Another interesting aspect of all of this is not just the reduction in healthcare demand, but also how care is being delivered. And one good example of this is within general practice. So while we don't have very good evidence from Ireland on general practice, there's quite good evidence from the NHS in England that has not only shown a large drop-off in visits, but how people are actually contacting their GP. So in February this year, across England, there were about 21.5 million visits. And in May, this had dropped to under 15 million. So quite a substantial 30% drop. But how care has been delivered has changed dramatically too. So in February, when things were working the way they should, about 80% of visits to the GPs happened on a face-to-face basis, and the vast majority of the time this would have happened within the general practice. However, in May, we're now seeing essentially a 50-50 split between face-to-face visits and contact with patients over the telephone. So about half of all GP contacts now in the NHS occur via the telephone. And this is important because when you think about the GP, they're at the front line of care. They deal with individuals with comorbidities, complex conditions. And we also know from evidence that many people who visit the GP for one issue, they may end up discussing other issues, and in particular mental health. So there's evidence that up to 40% of GP visits, for instance, involve mental health. And as we have a slightly different delivery of care, it may be much more difficult to diagnose or to treat mental health, for instance, or other complex conditions over the phone or through video calls compared to a face-to-face consultation. So just as a quick recap, it's clear COVID has reduced interactions with the healthcare services, but not necessarily the need for care. There still will be pent-up demand in the system for that. And it's also affected how, in many instances, people have interacted with services. And unfortunately, it's likely that the negativity or the negative aspects associated with lower use or differing delivery care methods will disproportionately hit lower socioeconomic or vulnerable groups.
Thanks very much. Thanks very much, Brendan, for an excellent contribution. One thing I meant to say earlier is that if you have comments and or questions, you're very welcome to post them on the Facebook page, and we will certainly have time for questions and comments near the end. So our next contributor is Dan Keller. Dan is a PhD student in the Cairn School of Business and Economics at NUI Galway. So Dan, over to you.
Thank you very much, Brendan. Hello, everybody. My name is Dan Keller. I'm a final year PhD student in health economics at NUI Galway. So migrant health-related behaviours and healthcare seeking practices is an area of research that I'm currently interested in and currently involved in. I'd like to highlight some ways in how migrants are a vulnerable group during the current pandemic. So keeping in line with the empathy theme of this talk, understanding how further vulnerable groups have been affected is very worthwhile for research focus and for policy focus. There's been a wide discourse which has highlighted how certain vulnerable groups, such as those aged 70 years and over, and those with comorbidities, have been affected by the current pandemic. I would like to provide 3 reasons as to how I believe migrant populations have been adversely affected. The migrant population in Ireland is substantial. There's 12% of the Irish population are non-Irish. This is compared to the 14% of the UK population which are non-British. But before I explain how migrants have been adversely affected by the current pandemic in terms of health and health outcomes, it is important to understand how migrants have always been considered a vulnerable group in terms of health and health outcomes, even pre-COVID. Migrants are a heterogeneous population, and the term migrant can be loosely interpreted as some migrants will be actively and successfully accepted into a receiving country, while others will face significant challenges. A migrant from the UK and a migrant from Romania may face different challenges while looking to reside full-time in Ireland. Migration takes the form of many guises, and as forced migration or voluntary migration. With each comes its own traumas and strains of the migration process. Legal entitlements to healthcare and the ability to adapt into a new society successfully. As a result, the type of migration that one experiences is important to the healthcare use and health outcomes a migrant may be expected to receive, and based on the level of migration that they would have to make. When a migrant arrives to a new country, they are already deemed to be different from the host population in which they arrive into, in terms of their level of health stock. Meaning, when a migrant arrives to a new nation, they are deemed to be of better health when compared to the native population. This health advantage is shown to dissipate the longer a migrant lives in a new country, as migrants are more susceptible to certain diseases, occupational health hazards, injuries, poor mental health, diabetes, and poor maternal and child health. Not alone do these differences in health levels become evident when a migrant is living in a new nation, migrants also have faced significant challenges when looking to access a healthcare system which they have no previous knowledge of or potentially no entitlement to. These issues come in the form of barriers to healthcare, which take the form of language difficulties, lack of understanding, costs and user charges, and overall lack of familiarity of the healthcare system they wish to access and what they need to access. Because of this, migrants then have differing health-related behaviours and healthcare-seeking practices when they are compared to a native individual from that country. Because of this, they've got different levels and different use of healthcare services. Migrants are characterised by having greater use of A&E services and lower use of preventive screening services when compared to natives. Migrants look to access more urgent care compared to non-urgent care in their host country, which is the country they currently reside in. To overcome traditional barriers to healthcare they just listed, migrants look to travel back to their home country to avail of care that they may not necessarily be able to access freely or easily in their host country. This leads me on to my first point as to how migrants are deemed a vulnerable group during the current pandemic. So migrants use transnational healthcare seeking practices where they travel back and forth from their host country to their home country to access care. But of course, during COVID, with travel restrictions and international travel restrictions imposed and cross-border movements prohibited, the care migrants necessarily may have needed and which they traditionally would have accessed by returning to their home country would have been stopped. This would have meant migrants would have had healthcare needs which they could not have accessed or addressed in their in their home country, the country of their origin. This would potentially worsen health outcomes for migrants. As travel restrictions ease, migrants may not be able to travel to access the care they want, even as travel restrictions ease, through fear of contracting COVID in the travel process. Migrants who are left at home left in their host country in Ireland or globally may not have access care they required during the pandemic due to lack of knowledge or ability to do so, and they may not have understood why certain healthcare resources and services were restricted. Migrant women have significantly less use of breast cancer and screening cancer services when compared to natives. They may have been more adversely affected during this pandemic, as their uptake may be slower when these services resume in Ireland. As Brendan mentioned, 45% of all A&E admissions have been reduced. As I just noted earlier, migrants access predominantly A&E services. They may have been adversely affected again here further by not being able to access the care which they would see as a traditional access and an immediate access to urgent care through the A&E, as they may have deemed this route unsafe and a potential leading cause to contract COVID. Language is not also a barrier for a migrant to access healthcare services. It's also a barrier for a migrant to access information on COVID, particularly on COVID guidelines produced by a country's own healthcare system or government. An example of this is in Sweden, where 25% of the Swedish population are non-Swedish, but migrants are overrepresented in the COVID-19 deaths in Sweden. And this has been somewhat attributed to the lack of information in migrant languages for migrants living in Sweden. Migrants may also face a difficulty in keeping abreast of national news and may face challenges when looking for translated materials. In Ireland, all translated COVID-19 materials are available from the hse.ie website under translated materials. The final point I will make on this is another reason how migrants can be deemed a vulnerable group during the pandemic is because they're living and working situations. The living and working situations of some cohorts of migrants may be another reason for this, or for making them a vulnerable group. It is noted that migrants live in intergenerational and high-density housing. They also work in precarious working environments and living situations which may make social distancing harder. The occupational health of migrants also tends to be worse than that of natives because they are overrepresented in low-qualified, temporary, and high-risk jobs, resulting in higher rates of occupational injuries and sickness presenteeism, which is when an individual works despite being ill, which may be a cause of disease transmission in Ireland and globally. Migrant workers make up 1/5 of the European workforce, but may have been the first to have been let go from their work during the pandemic. This will result in a massive loss of remittance globally. Remittance being where a migrant is working in their host country but sends back the money to their family in their home country. Studies show that international remittance from migrants to families reduces child labour and keeps children in school. With the projected loss of $110 billion due to remittance loss because of COVID, more children are at risk of being forced into child labour, which will reduce both health and learning outcomes of these children. And to conclude, migrant populations in Ireland and globally can be considered a vulnerable group. And the 3 points I made were due to their differing use of healthcare services, the language difficulties they may face in accessing translated guidelines materials and keeping abreast of national news, and their living and working situations. A final point to note would be migrant populations have markedly less use of preventative services when compared to natives, as I touched on already. This may have implications for vaccination uptake amongst migrants once one becomes available. This may be a key area for policymakers to address to ensure that there is sufficient level of uptake in the vaccinations by migrants in Ireland and globally. The challenges faced by all migrants in Ireland and globally are not equal, but some are constant and pressing. Migrant populations are resilient, and COVID-19 will only bring their resilient nature further to the fore. I hope this talk has highlighted the ways in which migrant populations in Ireland and globally can be considered vulnerable during this pandemic and may need some further levels of support. Thank you very much for listening.
Thank you very much, Dan. That was really interesting, and on a group that perhaps haven't received as much attention as they deserve in the past few months, at least in Ireland. So our next contributor is Dr. Michelle Queedy. Michelle is a lecturer in the Keller School of Business and Economics at NUI Galway. Okay, Michelle?
Thanks, Brendan. So good evening, everyone, and hopefully everyone is still with us, so we haven't bored you to log off. So as Brendan said, I'm going to have a chat about obesity and COVID, and I'm going to address 3 points, really. So first of all, to clarify as much as we can at this stage, what is the link between obesity and COVID-19, and then to think about the consequences that COVID-19 has had on people living with obesity. And then perhaps some reflection around thinking about what we've learned from COVID-19 and how we can apply that learning going forward in terms of our policy development and policy response. So the evidence, there is emerging evidence that obesity is linked with COVID-19 disease severity. And what the evidence is really suggesting is that people with obesity are at an increased risk of developing more severe symptoms or complications from COVID-19. So it's not suggesting as such that people with obesity are at a greater risk of contracting COVID-19 in the first instance. And indeed, we are learning more and more about COVID-19 and obesity with a huge amount of publications coming out on a daily basis. And I suppose it's the first time I found myself when I'm reading an academic paper looking at the date of the month that the paper was published rather than the year that was published, which is what I would have previously done. So I suppose that just shows the speed at which the research is being published and coming out. And some of it is excellent research and some of it is not, I suppose, not so excellent. But I suppose to give an idea of what the research around obesity and COVID is, so there has been a number of studies in the UK and Ireland and international of whereby we're trying to get a greater description or profile of people who have been admitted to our ICU wards. And for example, in the UK, some studies have suggested that people who are living with obesity are 44% more likely to become critically ill from COVID-19 compared to that of a healthy weight person. Another study in over, I think it was 17,000 hospitals in the UK suggested that people with the body mass index, a BMI of over 30, have a over 33% risk of dying from COVID-19 compared to those who are not obese. So those figures are quite stark. And in the Irish context, we know we are also getting a greater profile of our patients who are in ICU. And we know from the reports coming out that at the moment there's 16% of our patients in ICU are people with obesity or have a BMI of over 30. And there's a number of reasons why obesity or people with obesity are at a higher risk of developing COVID complications or symptoms. Some of them relate to the fact that obesity is linked with respiratory difficulties such as sleep apnea, obesity, hyperventilation syndrome, asthma, cardiovascular diseases, which can impair oxygen levels in the blood. We also know that obesity is associated with a significantly dysregulated immune system and also an impaired response to both bacterial and viral illnesses. We know that obesity is linked with inflammation, which may cause a more severe inflammatory reaction in the lungs with COVID-19 infection. So it's quite clear that there is a well-established link between obesity and the risk of developing a more severe form of COVID-19 in terms of symptoms and complications. So if we just take a step back, and I think possibly some of our lives are now kind of defined as before COVID and after COVID, and I don't think health economics is much of an exception there. A lot of things in health economics have changed pre and post COVID. And if we think about obesity before COVID came along, we know a lot about obesity. We know that it was increasing. We know that over 60% of the Irish population were either overweight or obese, with 23% of them being obese. We have statistics that say that 1 in 4 children are overweight or obese, 3 or 4 adults over 50 are overweight or obese. We know that obesity is associated with a lower socioeconomic status. So in other words, people who are from a lower socioeconomic background are more susceptible to becoming obese. There is a clearly established economic case for preventing and treating obesity, whereby we have shown that obesity can cost in the region of 1.6 billion euros on an annual basis. So thinking about that, really, I suppose, I actually think that, there has never, ever been a time really where obesity has been such a health and an economic priority. In essence, we're talking about really two pandemics meeting, and indeed the language around obesity up until now was such that we described it as an epidemic or a pandemic, and we all know COVID-19 is the pandemic. But to add to that, we have a situation whereby obesity is associated, as we now know, with complications and increased severity of symptoms in COVID-19. So I think it's really important then that, health economists are thinking about this and thinking about how we can shape or help advise, and drawing on some of what Paddy had said earlier, provide guidance around, resource allocation across our healthcare system. So up until now, a lot of what, Paddy would have talked about there, our health economic strategies would be applied in the healthcare setting, advising if a drug and intervention is cost effective. But really, when we actually think about the last couple of months, it's almost like the rule book has been thrown out in terms of health economics, because, a strategy was adopted whereby all resources were diverted towards managing COVID-19 cases, and rightly so preventing deaths. But now that we've kind of passed this firefighting emergency response to this first peak with, lockdown restrictions being easing, we're now talking about the trade-offs between economy and health. I think our thoughts are turning towards lessons that we've learned and how we can, apply those lessons to inform, future resource allocation, and to think about, those who have been more adversely affected, as Dan alluded to, as a result of COVID. And I think it was a Bono that said we're all in the same storm with COVID, but we're all rowing different boats. So something like that anyways. And I suppose that's so applicable when we think of our vulnerable groups like migrants or people living with obesity, that we appreciate that we're all in the same storm, but we also need to consider that some have been hit worse than others. And I think the people living with obesity and also migrants are one such population cohort. But if we think about obesity as well in the context of it affecting people across the life course, and we think about what the impacts of COVID-19 have had on that. So if we start at the very onset, of conception right through to end of life, we know that COVID-19 shut down, if you like, all of the antenatal breastfeeding meeting groups, lactation consultants, all of those groups. And the importance of that in the context of obesity is that, we're trying to get our breastfeeding rates up. Breastfeeding has shown, for example, that it acts as a protective factor against childhood obesity. How does that impact upon breastfeeding rates, early childhood prevention, and so on? When we talk about childhood obesity, we know, for example, that all of the schools were shut down. Children, we know, don't exercise like adults. They don't put on runners and go out for a run. It's a less structured, more play-formed form of exercise. We know that thinking apart from that, we know that there has been increased screen time with children. So thinking then through the life course of older age people, what effect cocooning might have had on their physical activity and indeed their dietary intake. And that's within a healthy population. So we're talking about, the healthy cohort, how people, how COVID affected the lives of the healthy cohort, and how, that might impact on the healthy cohort, translating into more levels of obesity or overweight. And if we then think about how it actually affected individuals with obesity, how the lockdown affected people in terms of food, exercise. We have two stories whereby some people might say that they had a great time with, taking more time to cook fine foods and etc. But that's not the case across the country. Obesity, as I said, is associated with a lower socioeconomic status. There's two divides, and I think one thing that COVID has done is really highlight those divides. We might have a progression of people going from a moderate, what we call a BMI of 30 plus obesity, to a more severe form of obesity. We've seen a new wave of stigmatization throughout the COVID pandemic, various memes and stuff, things like that, supporting, if you like, some societal views that obesity is due to a lack of willpower. social isolation is at the heart of obesity stigma. And we also know that there's a bidirectional association between depression and obesity. In other words, one can cause the other, or one is associated with the other. So how that has affected people with obesity during the lockdown. And also to think about, that's just people with obesity living in their day-to-day life. So what happens when someone with obesity is hospitalized? And what happens when someone with obesity is moved up to an ICU unit? We know that common strategies used to treat COVID-19 patients on the ward present a challenge when treating people with obesity. We have difficulty with intubation, extubation, getting IV lines in, insertations, risk of requiring more oxygen, proning patients to improve oxygenation in the lungs is much harder. We know that responses to antivirals and vaccines in people with obesity is reduced and is poor, and we know that people with obesity immune system is also compromised. So we also have to think about that when we are, talking about obesity and treating people with obesity in our ICU wards. So to kind of wrap up, I suppose, really thinking about, I think that COVID-19 has highlighted the urgency, first of all, in dealing with obesity as a disease. And by that, I mean providing access to care, whether that is preventative care and also treating obesity. So obesity, should no longer be seen as this sort of individual blame or a cosmetic condition, but a disease that brings considerable cost to society and also health risks to society. When you look at the extreme sickness of some people with obesity in ICU units. So I think, as I said already, the COVID-19 has highlighted the divide, if you like, and brought to fore how we need to kind of think about our resource allocation as health economists, and how I think, we have a place to sit at the table when it comes to thinking about the future of resource allocation in the context of obesity prevention and treatment. So that's it for me. Hopefully I wasn't talking too fast.
Thanks very much, Michelle. I don't think you were talking too fast at all. And so I'm just going to take a couple of minutes to talk about the question of vaccination. We're running a little behind time, so I might cut my remarks short because we've had some very good questions come in, and I'd really like to give time for that. So there's really just a few things to say about vaccinations from an economic perspective. And one of the things I'm struck by when I think about vaccinations is that we're in a moment where what economists might have said in theory a year ago has, to a large extent, been put into place, particularly in America. Because if you asked an economist a year ago, how should we get a vaccination for a virus like coronavirus, that the economist might say, well, what you need to do is you need to incentivize firms to spend a tremendous effort to find a vaccination for such a problem. You're not likely to pick a winner. You're not likely to be able to say at the start, it'll be Pfizer, but not Novartis who will find the right vaccination. So you want to have some kind of a competition where a lot of large private firms, in cooperation in many cases with researchers in universities, have strong incentives to throw everything they possibly can at the problem, knowing that some of them will fail. So how do you protect against that? You say to them, we'll cover your costs. And that's what an initiative by the US federal government with the rather strange name Operation Warp Speed has been doing for the last couple of months. And it's striking to me, at least, that we haven't really had such an initiative at the European level. There's been some effort by the European Commission to say that they will engage in what are called advanced market agreements, or contracts where the European Commission will make an agreement with a pharmaceutical company that will say we will guarantee that we will buy a certain amount of doses once a vaccination is available and give you the money up front. But I think it's disappointing from a European perspective that there hasn't been more initiative undertaken by Europe to directly fund the development of vaccines. So that's about the development. The second question is about the production of them, and it's a similar story that an economist a year ago would have said, well, what you need to do is, given the enormous number of doses that you need, you can't wait until the vaccination is developed to build the manufacturing capacity. You got to do that now. And so that is happening. There are firms around the world who are building enormous manufacturing capacity to make doses. So, for example, one of the vaccines that's getting a lot of attention is one that's developed in cooperation with the University of Oxford and AstraZeneca. AstraZeneca say that they believe that they will be able to make 2 billion doses of that vaccination by the end of the year. Now, we won't know for several months whether that vaccination is going to be successful or not, but that's an enormous commitment that AstraZeneca have made. The third issue, and it's a really difficult issue, and it's related to some of the questions that I see coming in on Facebook, is how to ensure an equitable distribution of vaccines once they're available. And it's an interesting phenomenon that has emerged in the last few months of vaccination nationalism, of countries basically saying, well, if we develop it, we're going to give it to our people first. And, we might, as a small country in Ireland, say that doesn't sound so good for us. We're going to be lower down in the queue, but it's at the same time, it's hard to argue. It's if you're in America and your government is funding the development of vaccines to an enormous extent, it might seem reasonable to an American citizen, at least, that he or she should have first dibs on the vaccine. That is, if the American citizen in question thinks a vaccine should be taken, because unfortunately, and this is my last point, unfortunately, there's a lot of evidence already around the world, especially in America, but also, unfortunately, I'm sorry to say, in Ireland, that a lot of people are very skeptical about vaccinations. We've seen this in recent years in Ireland with the very low, the large drop in the uptake of the HPV vaccine. Very happy to see that rate of uptake has risen again. But I think that there's no doubt that when vaccinations are available, governments and societies around the world are going to have to throw the kitchen sink at the issue of how to persuade people to adopt vaccines. And one of the things I was thinking about in relation to this is that it's not just governments that will do that. It's individuals, obviously, and communities. And we've seen that, I think, throughout the vaccine, throughout the pandemic. I mean, and Paddy has referred to it already, that, much of the response to the pandemic in producing health and in maintaining health and more broadly quality of life hasn't been about the state. It has been about communities coming together to provide for their neighbours and their families. And maybe I'll end on an optimistic note that maybe that'll happen as well with vaccines, that as communities we will encourage and really encourage each other to adopt vaccines when they're available. Now, it's 5 minutes left for questions. We might go a little bit over time if you don't mind, but I'm going to ask the panel to come back in. Thank you very much. And thank you all for your contributions. And so one of the questions that has come in, and it's possibly a perennial question for health economists, and is that how can health economists stand over the idea of putting numbers on the value of a human life or the value of health. That's a question that I think any of us who have taught health economics, all of us here have taught health economics, we're often asked that by our students. And I see Michael from Clontarf has asked us that question. Paddy, do you want to have a go at that, at defending the economics approach to these difficult questions?
Thanks, Brendan. Thanks for the question. I think these are hugely difficult questions to address. And, we're all individuals. We all have families. We all have loved ones who, from time to time, require healthcare. And, you would spend anything on to ensure that they get access to the care they need. The way I think about this, and this is a personal thing, I don't know if I'm right or if I'm wrong, but decisions have been made every day and every hour in healthcare systems since they began, where a rationing process took place, where somebody gets access to a service, a healthcare intervention, whatever it is, and by making that decision, somebody else didn't get access to that healthcare. Now, that has been implicit for decades, it's been implicit for years, but that decision has placed a value on the health outcome of the individual that got the service and the individual that didn't get the service. And for me, and how I kind of justify this, if you like, to myself, is that the kind of methods we employ is we try to make that implicit judgment explicit. So we estimate, and we do our best and are very careful in how we do this, but we estimate the health outcomes associated to a particular individual of getting a healthcare service, and we estimate the cost. And we do that in a transparent way so that the decision makers know explicitly the implications of their decisions. We call it opportunity cost. By giving a service to one person, we can't give it to somebody else. And that's a very simple explanation, but I think that's key. We're making explicit, if you like, the implications of these decisions that were implicit for years. And the result of that may be that you still make the same decision, but it may be in some cases you make different decisions. And I guarantee you, if you asked everybody on this panel, we don't feel that we are empowered or have more knowledge than any doctor or should be the person making these decisions. All we're trying to do, and all we would advocate, I would suggest for my colleagues as well, is let's produce high quality evidence so that when we make these decisions and we assign these values, that we do it explicitly, that it's transparent, and then we can live with the decisions that we make. So that's my answer.
Good. Thanks very much, Paddy. And in fact, just what you said there about evidence leads me on to another question that was posed. And maybe, Brendan, might take this. It's the question of data. And I suppose it's often, again, as practicing health economists in Ireland, we're often maybe look at other countries and roll our eyes and think, oh, wouldn't we like to have such better data? Do you want to make a few remarks about the data restrictions that have affected you and your colleagues at the SRI in your work?
Yeah, I think Paddy's made some of these points just now. So, like, the quality of research is only as good as the data and information that's available to researchers. And similarly, like, policy needs to be based on evidence, which itself needs to provide on, good data and a good data infrastructure. And while I don't think the crisis has identified gaps in the data and the data infrastructure per se, it's certainly shone a light on the data gap. So in Ireland, for instance, we do know that in general we have quite a poor data infrastructure. There's quite a real lack of data on healthcare use on patients and providers. And there's also, which isn't talked about enough, there's also the inability to join up different data sets. And all of this does really impede policy and good evidence and good research as well. And when you think of the COVID crisis, because decisions need to be made in such a fast manner, often hour to hour, day to day, when you don't have this information and the data infrastructure set up, it also negates the ability for this quick decision making. And it's happened here and it's happened in other countries too. I do think researchers in a lot of places have actually stepped up quite well. So from an Irish perspective, there's GPs involved in GP Buddy, for instance, and they've provided an online resource for GPs whereby at the end of the day, they're able to provide information on people presenting to their practice with either COVID-19 type symptoms, or if they have been received a positive COVID-19 result. So it's through this webpage called GP Community Tracker. And it's just quite a simple method, about 150 to 350 GPs per day. It takes them about 2 minutes. They respond online. And while that may seem quite simple, that's some of the best information we actually had on day-to-day, symptoms and infection rates. And it actually was fed into the NPHET procedures and the policy they implemented. And there's also some other good examples from the CSO. There's researchers in NUI Galway at DCU who've undertaken these very large data gathering exercises to try and understand how society is coping with COVID-19 across, different dimensions such as health, well-being, social connectedness, support, and so forth. So while it's, there'll always be data issues, I do hope that, this pandemic will be the catalyst for us to maybe really try to ensure that people realize that, evidence and research requires high quality data and quite high quality data infrastructure here.
Thanks very much, Brendan. Dan, I was struck in what you were saying about the remittances. There's so many things about the pandemic, and then there's something that you say, "Oh, I never thought about that at all," and that certainly is in that category. And here am I reading about this issue for 3 months, and I'm delighted that you were able to surprise me with that. But do you want to say any more about that issue in terms of you talked about the potential negative impacts of lower remittances in the countries of origin? Is there data already that suggests that families in those countries of origin are suffering because of a reduction in remittances?
I haven't seen a study to show a reduction in outcomes of the study of the families who are not receiving the income supports. That was an EU study I did see, but it's one of those unfortunate consequences that, as you said, like people you wouldn't think of it, and
Yeah.
it does show, I suppose, the need for strong economic policy. And again, I'm going to very vary into territory. It's not my own. It's a health economist. But you do see the extra knock-on effects, and they are numerous, and they are going to be constant, and they probably will not come to light potentially for the extra 2-3 years further down the line. So again, it's just another thing to be mindful of, and there really is real risk for these families who are so dependent on a migrant worker abroad in Ireland or somewhere in Europe. These people, they have severe dependence. This crisis is affecting a lot more people. And I think Michelle's analogy of we're all in a storm but in different boats, and it really is highlighted there where these individuals are seriously struggling, and they've got families. It's not just the individual themselves that's struggling, it's the family that's back home that is very reliant on that person.
And Michelle, one of the things that I was thinking about listening to you was, that the pandemic has given societies space to think about maybe alternative physical environments, and we're based in Galway, most of us here, and there's been talking about pedestrianising more streets and making cycling more accessible to people. Are you optimistic that some of those environmental changes might have a long-term impact on the problem of obesity in Ireland?
Yeah, I think, Brendan, like a lot of the approach of what we kind of need to start doing is thinking about it from a systems approach. So in other words, obviously, there's the clinicians, but in the context of obesity prevention, the medical side, but obesity is such a complex disease. It draws on biological, genetics, environmental, and economic as well. So I think our response to it, whether it's preventive or treatment, should incorporate things like what you were saying. And I think, we should be drawing on other areas such as, transport, agriculture, behavioural, labour, even the political economy, what's happening in Ireland at the moment. You look at the new programme for government, and it's broadly based around preventative healthcare system with regards to obesity. But I think, from looking at data from other countries, you can't really, it's challenging to look at one thing. For example, if we were to look at what you said, cycle pathways or greenways, does that affect obesity? I think it has to be one of a number of other things. So for example, one thing like along what you're talking about there, the cycle tracks or pedestrianising. And I think some areas in Galway, in fact, have been quite successful in pedestrianising walk areas to schools at certain times and hours. And I think initiatives like that, even at a local level and eventually at a national level, will help I suppose the fight against obesity in terms of preventing obesity. But it's one of many things that need to be done. No one thing is going to sort of solve the issue of obesity. But I think, yeah, definitely it's something positive that we can think about. And I know there's a lot of campaigns going on in Galway and also at a national level to try and do that. And we can draw on European countries that have successfully done that. Paris, pedestrianised and zoned a lot of the cycle spaces. So yeah, I think it's definitely something that we need to consider.
Great, thanks, Michelle. We've got another question here from someone I think we all know. Edward Henry is wondering about what do we think about a contact tracing app being used all over Ireland, given the free free travel between Northern Ireland and the Republic of Ireland. While you're thinking of your answer, I just say that I was struck in the last couple of days that there's been this enormous take-up of the contact tracing app. I think on over 20% of the population in Southern Ireland have signed up for this app already. And I was thinking about why is the take-up there so good, and if any of us have time later to go into our local supermarkets, I'd be very surprised if we'd find that the take-up of wearing masks indoors would be anything like 20% at least around Galway. And I was thinking about this question. This is kind of, if you like, a community response. We're quite happy to download an app, but putting something to cover our mouths and noses seems to be a little harder. And I was thinking about that in the context of vaccination take-up. And maybe this is getting a little carried away, but I was wondering that maybe the community, once we have a vaccine, needs to start telling each other we've been vaccinated. So anyway, that's not was all by way of giving you time to think about Edward's question. Does anyone want to respond to what Edward said about the tracing app being available both north of the border and south of the border?
Yeah, this is Paddy here. Absolutely. Nice to hear from Edward. And as somebody that grew up close to the border and crossed it many times, when you're living up there, you don't think of a border, I guess. Well, not at the moment. So, and I suppose if, we've anecdotally, you would have heard of, folks crossing the border and the different policies and the implications of those and the concerns raised over those. You would like to see more of a collective policy response for the island. One of those aspects would be the collective tracing, but also the point you raised, Brendan, is an interesting one as well around when hopefully we get to that point when the vaccine comes, those that are vaccinated and those that aren't. But certainly it makes sense that it would be on an all-island basis.
Earlier I was wondering, should I start producing car stickers saying I got vaccinated? So that's it as regards questions or comments, and I'm just going to draw the event to a close, if that's okay. I want to thank all of my colleagues and fellow contributors for their very interesting comments and contributions, and thank you for giving us the time. Can I thank Catherine White and Professor Lorraine Leeson as well for interpreting us so well into ISL. and thank Dave for ensuring that everything went smoothly technically. And behind the scenes, I want to thank our colleague, Dr. Anna Hobbins, who was looking after the questions and comments and was feeding them to me as they were coming in. Thank you, Anna. So lastly, there's just one more webinar left in this series, and it's a very exciting one. Next week, it's going to be a kind of a catch-all or a capstone webinar. It's going to be chaired by Kitty Holland from the Irish Times, and it'll feature Professor Pat Dolan from ILAS, and will also feature President Ciarán O'Hogartig, the president of NUI Galway. And I'm looking forward to that, and I hope many of you will be able to join us then as well. So thanks very much for watching, and we really appreciate the audience. Thank you. Goodbye.